Hi, hello, welcome back. Let me discuss a very interesting case of a 70-year-old diabetic who presented with coma. These are the MRI diffusion weighted images. Any clues? What is the diagnosis? Okay, let me discuss a very important entity today, which is called adult hypoglycemic encephalopathy. If you don't diagnose it at right time, you may really cause a significant debilitation to the patient and you may lose the life. Sometimes in acute emergency setting, as soon as they see the patient in coma, they shift to the imaging studies before the investigations arrive. So they would have taken a blood, serum, glucose, everything, and they would have sent to the lab, and they will be waiting for the results. And immediately, meanwhile, they will get an MRI. Before the results come in MRI, you can see these findings, which are hyperintensities in the bilateral corticospinal tracts, especially in the corona radiata, and bilateral posterior limb of internal capsules. Normally, this posterior limb of internal capsule hyperintensities are seen to certain limit, but not in the level of you getting a signal in the ADC. The ADC signal is pretty dark in this case. So based on this finding, we made a diagnosis of adult hypoglycemic encephalopathy. Then the patient's clinical presentation was fitting and his serum glucose levels were less than 50 milligrams per deciliter. So it is also called as diabetic coma. So again, I want to impress upon the finding, which is common whenever you see this diffusion restriction posterior limbs bilaterally. You have to think whether is it normal or is it, how is the patient condition. If he is very sick, you have to think about hypoglycemic diabetic coma. Immediately, it is a 5-minute infusion of calcium gluconate or sugars, patient will recover. If it is more superficial, if it's not that profound, other areas like parietal, temporal, occipital lobes, basal ganglia, hippocampi may be involved. There will be gyral swelling, cortical hyperintensities, diffusion restriction. Generally, these paired areas, thalami or cerebellum, are generally not affected. This is how you differentiate it other causes of other metabolic causes, especially hypoxia. In hypoxia, thalami and cerebellum are involved. So these are the imaging findings. CT, you may see the hypointense, all these areas like hippocampi, putamina, there will be diffuse cerebral edema, there will be gyral swelling, and hyperintensities will be seen in parieto-occipital cortex. And if you do the MRIs in later phase, you may see decreased NA and increased lactate due to anaerobic metabolism, which reflects the neuronal damage. Differential diagnosis are acute cerebral ischemia. If it is unilateral, you have to think about acute cerebral ischemia. Bilateral, it's relatively rare. Thalami will be not involved in hypoglycemic encephalopathy. They will be involved in hypoxic ischemic encephalopathy, and rarely press will have similar findings. So this is the trigger factor is insulin, and night time they'll take a sulfonylurea and insulin, and they don't take proper food, which may affect and trigger the glucose depletion. And this is mainly excitatory neurotransmittory accumulation and laminar necrosis. So it's always useful. Diffusion is most important sequence, and this is sparing pattern. Again, I want to emphasize on thalami and cerebellum. Thank you very much. And other literature you can go through regarding this is you have given the literature. Hope this video on adult hypoglycemic encephalopathy was useful.